just figure out what our legislation would be. And we had 3 different drafts, and they've been sent around. Is that correct, Sarah? Okay. The first draft was to set up a behavioral health commission. Now, I sent you some ideas. Did you incorporate those ideas? Okay, I sent them to Tracy. I assumed Tracy sent them to you, and maybe she didn't.
I think this was the email I got today. There was one idea for this one, or was there more to this?
There was one idea. Here's the thing. If everybody's reviewed the Behavioral Health Commission language, the language is all right with me. What I worried about was it continued 7 members of the House and 5 members of the Senate. That's fine with me, but a lot of people are hung up on numbers. Well, I suggested that if we are going to keep that membership as it exists today, that we include in there the language that basically says that any recommendation of the commission has to be agreed upon by a majority of the senators and a majority of the delegates. Is that all right? Okay, Sarah, I'm sorry.
Yep. And that's actually, if you look on line 46 of the draft, it says no recommendation of the commission shall be adopted if a majority of the Senate
okay
the vote against it. So we've got that. I did get that one in there.
Okay, good deal. Good deal. Okay, does this draft look okay with you all, or are there other approaches you want to take to it? Well, the enactment clause, I think, covers the possibility that we can't fund the commission. Is that correct, Sarah?
Yes, Mr. Chair, that would cover, really if you have an instance where funding isn't included this year, gives you a year of sort of grace to.
Okay, well, and that basically, this commission will, technically will exist for another year anyway. So this can either we can fund it and do it this year, or we can wait till this commission expires, this joint subcommittee expires, and then let the commission take over. We can do it either way, I guess. What are your thoughts?
Mr. Chair, also, yes, you could establish it this year and use that year to do a transition year as well, if that's members are interested in that.
Okay. What are your thoughts on this? Delegate Price.
Yes, Mr. Chair, I just wanted to see, because I am looking at the composition of the Deeds Commission and seeing if there was any possibility that this could get funded this year, or are we operating under the assumption that it would not happen this year, and that's why the language is in the reenactment clause the way it is?
From my perspective, it seems to me that there's every opportunity to figure a way to fund this year. And I'm going into it thinking we're going to do that, but I want to also be careful that we make sure that these issues aren't left floating in the event that something happens.
Thank you, sir.
Mr. Chairman?
Yes, sir.
Yeah. What kind of money are we talking about here?
Well, we're talking about 2 or 3 staff people. I'm not certain if we've actually got a dollar figure on that. Sarah, do we? Okay.
We do not yet. It would depend on the number of staff you would want, and if we need any additional budget for hiring experts and consulting services.
Honestly, the appropriations process, Madam Chair, has been very kind to us over the years. But Sarah, do you know what our annual budget typically is?
I can't remember what the annual budget is. We also had additional funding that was set aside. It was sort of unusual for a study where there was a sizable amount of money set aside to support the work of this joint subcommittee. We don't usually see that. If you can give me a moment, I think I can find our annual appropriation. I just don't have it in front of me right now.
In any event, we've typically had money to hire experts. And I would anticipate that we would, and we have, as I've said before, we've relied entirely on the largest of the Division of Legislative Services. I would anticipate that we would probably need 2 or 3 people at a minimum to staff this up.
Mr. Chairman?
Madam Chair, yes.
I'm totally supportive of having this become a commission, but it seems if we haven't worked out those details yet, it's kind of late for a short session to pull it off.
Well, that even more reason to have that enactment clause then.
Yeah.
If we can transition, if we can get this passed, we can transition the last year of this joint subcommittee into a commission. Next year, we can get it funded.
Mhm.
Is that what the way it's really set up to work anyway, isn't it, Sarah?
Yes, so you could do that, or you could put a delayed effective date. If there was concern about funding, you could also look at putting a delayed effective date on the legislation that would put it into the code effective this year, but it wouldn't really kick in until next year. So that's another option you could consider. That way, you know, it's in code. It gives you a little time to work out the funding.
My concern about not doing something this session is that the joint subcommittee expires at the end of 2021. And so if we don't have something in place at the end of 2021, these issues could languish. And I don't want that to happen.
Agreed.
Well, is there a motion that we introduce this? I've got space for it.
So move, Watts.
Second, Price.
Okay. Any further discussion? All in favor, say aye.
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 Any opposed? Okay, I'll introduce that bill. The next one is a mandatory outpatient bill. And as I recall from our last meeting, there was a conversation between Delegate Bell and Delegate Hope. And Professor Bonney was also involved in that discussion. I don't, does this bill reflect any sort of agreement with you all?
Well, I mean, I don't want to speak for Delegate Bell, Mr. Chairman, but we did have a conversation with Delegate Bell, but I do want to level set with the commission here. There are a couple of things that we're trying to do with this bill. There are some substantive changes that we've been trying to make in this area of mandatory outpatient treatment for a while now. But then there's also a accompanying reorganization to drafting the bill. And I think we've realized that the reorganization is much more complicated than what we had intended, especially in a short session. And so what I've decided to do is to moderate our approach, to just take up the substantive changes in this short session and convene a working group and to ensure that this commission is directly plugged into this process for the reorg to make sure that we don't miss anything. And I think there are some concerns that were raised by the Supreme Court and the Inspector General, enough concerns that you worry if you do want something on one end, like the MOT, that you might be also doing it on the inpatient side. And we wanted to avoid any issues related to that. So for this session, I want to take two bites out of this apple, one this session and another in the future. And in this session, I want to look at the substantive changes. And what I've told Sarah that I would do is ask if she would walk through for the commission the substantive changes that we intend to make for this coming session.
Okay, Sarah.
Okay, and this was the draft that was distributed to all of you on Saturday, I think. Lost track of what day it is. I want to caveat this with, we are still refining some of the pieces of this. So there are some changes that will happen as we make sure the wording of the draft actually accomplishes the intent of the work group that put it together. I'll do a sort of high level overview of what changes. If anybody has any specific questions, I'm happy to answer those as well. So this draft is going to change primarily the provisions of the code related to mandatory outpatient treatment. As we move through that draft, you'll see some changes regarding how the CSBs that are involved in this process, the initial part of the hearing, will communicate regarding meeting dates and times. Moving along from there, one of the biggest changes is a change, it's on page 4 of the draft that I sent you all, in how step-down mandatory outpatient treatment will work. This is one of the areas where we're finding a little bit of language, but what this draft will do is it will remove the physician from the decision-making seat in step down. What will happen under this draft is there are three ways, so three options available here. One is inpatient treatment, an order for inpatient treatment only. One is an order for outpatient treatment only. The third is the order for step down. The way it works under the code currently, the judge enters a single order, judge of special justice enters a single order for step down, which is a total of 90 days in duration. And some portion of that time period will be inpatient treatment, and some portion of that time period will be outpatient treatment. Currently, the treating physician has the authority to determine when the person will transition from inpatient to outpatient treatment. There is criteria in the code set out. They have to measure, look at, and make sure the person meets those criteria, and then they can make the decision to discharge the person to mandatory outpatient treatment in compliance with the treatment plan. This bill takes the physician out of that process. What will happen is that if the preliminary hearing, the first hearing, an order would be entered for mandatory outpatient, or mandatory inpatient treatment, which is the 30-day inpatient treatment that we currently have in the code, plus a period of mandatory outpatient treatment that begins whenever that inpatient treatment ends. The new mandatory outpatient treatment would be for up to 180 days. So it has the effect of extending the overall duration, possibly, of the two orders combined. There is no decision-making point in this process where somebody has to say, this is the moment where the person meets the criteria to transition from inpatient to outpatient, but rather under this draft, there's an inpatient order, and then there's an outpatient order, and the transition happens at the time the inpatient order expires. There are some provisions in the code that allow for a person to be released before the end of that order if they meet criteria that indicates they no longer meet the inpatient treatment criteria. That's in another section of the code, but this is a pretty substantive change to how our current step-down orders work. Are there any questions on that before I move on?
Mr. Chairman, I have a question.
Senator Mason.
This is Sickles here.
I'm sorry, Delegate Sickles, I apologize.
Yeah, I know we look alike.
Sound
So just general, how closely have you worked with the CSBs on this particular portion, or have they or some of them concerned about it, or have they signed off on it as a group?
Mr. Chair, I have not had any contact with the CSBs regarding this draft. These are the recommendations that came out of a work group organized by the ILPPP and DDHDS over the course of last and into this summer. So that may be a better question for Dr. Barnes on the call.
Dr. Bonnie and Allison Teisinger from the Attorney General's office are both here. I think, Allison, were you involved in drafting this? Can you?
Hi, Mr. Chair. No, I was not involved in the work group or in drafting this. So I'm here today to help answer questions if you'll have them, but I have not been involved in the drafting.
Professor Bonnie, what say you?
So if the question, the CSBs were involved in the drafting. We had a number of members of the work group that are emergency services people, of course, from the CSBs. I think Jennifer Faison was also involved in this, but obviously at that point, no formal action, was taken. We did, there was nothing there to take action on. My understanding is that now, obviously, that we have a proposal here, that there'll be something for them to take a look at. I think they'll have to speak for themselves about this, but we actively engaged all the people from the CSB in the discussions about this.
Well, Mr. Chairman, to follow up, just for what it's worth, the Fairfax Falls Church CSB is really concerned about this, and had a call with the director, and Jennifer Faison was on the call. I don't know if they read anything that's out there, but so maybe when they see this document, all their worries will be assuaged. I don't know, but they are very concerned about it in my neck of the woods. Over.
Okay.
Senator Deeds, I have a question.
Delegate Ransom.
But
There we go. I'll unmute it now. Okay. So we're taking the doctor out of the process. Is that what I'm understanding? And the step down. So who evaluates the patient when they're being released? Who steps in?
Mr. Chair, that's a good question. So in this case, there isn't an evaluation at the point of discharge in most cases. What would happen is, from what I understand of the intent of this piece on step down, seems would happen is that when the initial order is entered, first it's essentially an inpatient treatment order, which is for 30 days. That's the statutory duration of the inpatient treatment order. There are some provisions that allow treating providers to let that person go from that order earlier if they meet certain criteria. Those are in other code sections. But under this model, you would have 30 days of involuntary inpatient treatment under the first order. There's essentially a second order for mandatory outpatient treatment that would start whenever the person's inpatient order comes to an end. So usually at 30 days.
Okay.
Starts. So there is no evaluation by a healthcare provider to determine if the person is ready to step down like you have now. It's just an order and then another order. And the transition happens at that time. Dr. Bonnie may have more.
Yeah, Sarah, I thought we had discussed this this afternoon, and my understanding is not what you just said. There would be an evaluation of suitability for discharge that the treating physician would make as to whether the person was ready for discharge. That could happen before the 30-day period, but then once the person was discharged, they would be subject to the mandatory outpatient treatment order that had been issued in advance at the time of the original commitment proceeding. That's, I think, the intention of the work group. And I thought as you know, we've discussed this a lot.
Mr. Chair?
Sure, Sarah.
We did, and then there was the string of emails that seemed to be encouraging sort of the opposite perspective. So this is, as I said at the beginning of this, one of the places where we still need to refine what the intent is and how it's going to work. If the intent is to have a setup where the order is entered, there is some period of mandatory inpatient treatment, and then at the end of that time period, the mandatory outpatient treatment order kicks in. The way the draft is currently written doesn't make that clear. So what we need to do is we need to revise this language in C1 to make very clear that that's the process.
Yeah, well.
Now, currently, the language that allows a doctor to discharge a person prior to the end of an involuntary treatment order basically says they have to find that the person doesn't meet the criteria. And that exists in the code. It's in a separate code section, has been in place through the duration of our inpatient treatment orders as well. The step down order is a bit of a different approach currently, where there is a single order, and as part of that order, the treating physician is specifically authorized in the mandatory outpatient treatment order to make the decision when that person is ready to leave inpatient and transition to the mandatory outpatient. So this would be a different setup, and I think if that is the intent, to continue to have the physician make the decision as to when the person is ready to transition from inpatient to outpatient, we need to look at the criteria that are currently stricken from the draft.
Well, I think this is a drafting issue that, well, obviously we'll have to continue to work on. I think just in terms of what the work group intended, I'm confident that the work group intended for the physician as now to make the decision about whether or not the person was ready for discharge, including that they don't meet the inpatient criteria anymore. Right. So it is a commitment for up to 30 days, which it now is in the code, for inpatient commitment. Once the person is ready to be discharged and suitable for discharge, which is a decision that should be made clinically, then the mandatory outpatient treatment order will kick in for up to 180 days. They meet the criteria for mandatory outpatient treatment, but they no longer meet the criteria for the inpatient commitment, and they are otherwise clinically suitable for discharge. I think that is clearly what the group intended. And as compared with the current law, the only thing that we intended to change wasn't that the attending physician makes the decision as to whether the person is suitable for discharge. It was to get the physician out of the business of assessing whether or not that this was a suitable case for a step down mandatory outpatient treatment order, which the judge has already made at the original hearing, right? So the language that takes the physician out wasn't to take the physician out of the clinical decision about whether or not the person was suitable for discharge, but rather to take the clinician out of the decision about whether or not this is a suitable case for mandatory outpatient treatment, which the judge has already determined. I think that's what the committee intended, and I think that we're just having a drafting issue here, is my interpretation of this.
Delegate Bell, you had some input on the development of this law and to a large part. Have you looked at this draft? What do you think?
We have the problem of having too many discussions with too many drafts. I mean, I might kick back to Sarah. I'm not sure. We had a lengthy call with Delegate Hope, just walking through the provisions. This is much more concise. I don't want to speak for Delegate Hope. To Delegate Sickles, I would say there is no way to make the committed person and the CSB and the doctor and the family members happy. It's not, those are in some places, those are in conflict. And I do think that if anybody thinks there's a way to square that circle, it's not possible. In other words, the committed person largely doesn't want the oversight the family does. The CSBs we would rather they be outpatient than inpatient, but that does require some resources that would otherwise be provided in the hospital setting to be provided by the CSBs if we want to have confidence that they are being followed and kept up with and make sure that they are safe outside. So I don't want to step over Sarah's presentation, but for example, Sarah, some of the other language we've talked about for the last few days, I don't know if that's in here or not. If it is in here, we need to make sure that the commission sees it. If not, then we need to talk about stuff that may want to be put in it as this goes forward through the process, assuming the commission wants to endorse it, which I hope they do.
Okay, Delegate Hope, I'm a little confused. Why would the Fairfax Falls Church CSB express concerns? I mean, I thought you guys in Northern Virginia talked to one another.
Well, this surprises me too, and I'm surprised that I'm hearing about it now, because I think that we took great pains to bring in the CSBs into this discussion, and I know the CSBs were probably concerned about any type of monitoring that they have to do. I just want to remind the commission that MOT already exists; it's already on the books. We're not creating a new tool here. This is already there. But we are putting in code that you're going to have to follow the individual because we're worried about what happens if someone doesn't get followed. And I think that's the crux here. I think that's a policy decision that we all have to make. To Delegate Bell's excellent point, you're not going to be able to make everyone happy in this, but I think the policy is if someone can better be served in an outpatient setting rather than an inpatient setting, it's the least restrictive means, then we should do it. And I think the whole purpose here is to write a code in such a way that allows for that opportunity for that option to be available in some areas or some places that it's just, they don't have the resources, and I understand that. But for those that can do it, we want to make sure that the code expressly allows that and is readable and understandable to do that. There's some substantive changes that we are making here. But to your question, Senator Dees, I am surprised that they're lobbying Chairman Sickles on this bill. I do believe that my CSB supports it.
Yep.
Sarah,
can I follow up on that? I mean,
Delegate Sickles.
I am not an expert here. This is kind of new to me, but they're concerned that they believe they have numbers to prove that they're keeping more people out of institutions in any other CSB area in the state. They know their patients, they know them well. They provide more community supports in other places. You know, Fairfax has $120 million of local money in their system, and they're afraid that their success is going to be jeopardized by being forced to do things they know they can't do and shouldn't be done with a certain. I don't know why they believe that exactly, but that's they don't want our oversight. They think they're doing a good job now.
Well, I'm interested in making sure we don't disincentivize that local investment in mental health care. But I want to make sure the MOT law does what we always thought it could do. And I'm not convinced that it has worked as well as it should. Sarah, was there more of the bill you wanted to walk through?
Yes, sir. We've touched on one of the other significant changes in this draft, in this discussion. One of them is the duration of mandatory outpatient treatment. This draft would change the duration of mandatory outpatient treatment, either the step-down model, which we clearly still need to work out the details around, or the sort of straight MOT from 90 to 180 days. Another important criteria change that I'd like to draw your attention to is a little bit of language in C and C1 about when we're looking at a case where a person is coming to the end of an inpatient treatment order, there are provisions for a sort of separate process to get a new order for mandatory outpatient treatment that will become effective when that inpatient order is about to expire. And then also that's the criteria we'll now point to under our step down outpatient treatment. Changes the calculation of that time period. It's a 36-month time period that we're going to look back to determine whether the person has previously been the subject of involuntary, or has been involuntarily admitted or subject to a TDO. This bill draft does tweak that language to make clear that that time period will not include any time during which the person was receiving inpatient psychiatric treatment or was incarcerated. So it could have the impact in certain cases of expanding the look back time period when we're determining whether the person should be subject to mandatory outpatient treatment upon discharge from an involuntary treatment order. Moving on from there, you'll see throughout the draft that we changed the term discharge plan to a mandatory outpatient treatment plan. Currently, discharge plan is the term used when we are talking about a person who is going from inpatient to outpatient pursuant to a step-down order. And mandatory outpatient treatment plan is generally the term we use for a person who is going directly into mandatory outpatient treatment with no inpatient commitment. Seems like a small change, but it does require us to make sure that we have all of the procedures and processes and criteria lined up appropriately when we combine those to just simply have a single mandatory outpatient treatment plan, regardless of how you come to mandatory outpatient treatment. Moving from there, you'll see towards the end of the draft, we amend several other sections. 37.2-817.1 addresses monitoring of mandatory outpatient treatment. We've changed the term throughout the code from compliance with the order and plan to adherence to the order and plan, or adherence to the plan. This section also changes terminology around monitoring of mandatory outpatient treatment to make clear that we will be looking for material non-adherence, which is defined now in the code, and lays out the process that the CSB needs to follow, or some elements the CSB needs to satisfy in terms of undertaking that monitoring, including contacting or making documented efforts to contact the person regarding the plan and the supports they need to comply, and contact with service providers. That is on page 10 of the draft. One point that Delegate Bell brought up that is not in this draft, he and I have talked about it since I sent this out to you to make sure that you had time to review it before our meeting, is some additional requirements around the CSB's monitoring role. Under the current code, when a CSB is monitoring an individual who is subject to a mandatory outpatient treatment order, one of the things that they're looking for is to make sure that the person's condition does not deteriorate to a point where they are now subject to or meet the ECO criteria. The reason for that is because if you have a person who is not complying with their mandatory outpatient treatment, and as a result of that begins to experience a crisis, the CSB needs to know when they need to obtain that emergency custody order to address their safety and the safety of others. So Delegate Bell was concerned about making sure that that monitoring was happening. And we have come up with some language that would be added to this bill that would add to the comprehensive outpatient treatment plan a requirement that the plan set out the provisions that the CSB will follow to ensure the person does not meet the criteria for emergency custody or temporary detention at any period during the mandatory outpatient treatment order. Those will be the specific steps the CSB has to take to make sure that the person does not at any point in time during that order meeting the emergency custody or temporary detention order criteria. And then a corresponding change farther down in the bill that makes clear that the CSB will have to report to the court what it is doing to satisfy those criteria at least monthly. Are there any questions before I move on from any of that?
Mr. Chair, I had a question. This is Delegate Price.
Delegate Price, I'm sorry.
No, you're fine. Thank you. Sarah, can you repeat for me, there was an increase from 90 days. Can you go back over that part? I'm trying to track everything.
Yes, and I'm sorry, it's a lot of changes, and I wasn't there's no good way to explain all these in detail without going too far into details. So it's helpful when you all let me know the specifics you're concerned about. Delegate Price, with regard to the piece that you are asking about, right now, mandatory outpatient treatment, if that's the first order that's entered, it's just a mandatory outpatient treatment order, is for 90 days. If you have a case where a step down order, as we call it, it has been entered, which is an order for a defined period of time, some of which will be inpatient, some of which will be outpatient. The combined total of that order is currently 90 days. So within those 90 days, you'll have some amounts, maybe 10 days of inpatient treatment, followed by 80 days of outpatient treatment. And that's the case where the treating physician makes the decision when it is appropriate to transfer for the person to go from inpatient to outpatient. This draft would extend those time periods to 180 days.
Jennifer Faison, I see a hand up. Is that what do you want to ask a question?
Hi, good afternoon, Mr. Chairman and members of the committee. I had signed up to do public comment, and when I saw some of the beginning conversation here, just wanted to jump in and clarify. Delegate Sickles, the bill that we were talking about, and I appreciate your channeled righteousness, was actually having to do with a bill that I believe the department is going to be submitting related to the discharge planning process with the state hospitals, which is a different issue than this bill. And we are very concerned about what that might end up looking like.
But I want to clear up then, the Fairfax Falls Church CSB is not concerned about this bill.
So we had the draft that the ILPPP put together in conjunction with the Treatment Advocacy Center, and we reviewed that. We do not have, or actually just received the current draft with some of the additional revisions that Sarah Stanton is talking about. So we will be reviewing that draft, but the concern that we had was with discharge planning, not with this particular bill, since we're just in possession of this most recent draft. Okay. I will say we would be looking at to ensure, just as delegate, or just as some of the members have expressed, we would be looking to ensure that there's still an ability for the CSB to say, based on the services that are available in this particular area, we don't feel like we can safely support this person in the community. So we'd be looking to see that that was still in there. We would be looking to ensure that whatever the proposed requirements are for the CSB in terms of monitoring make sense and are realistic. I think it would be impossible to say, we're gonna have a hotline to this person 24 hours a day, 7 days a week, in the event that he or she might wake up and not be feeling so great. And the ECO process exists by default to address those situations when a person is decompensating. So would have to see what that looks like in the context of mandatory outpatient treatment. But I did want to clarify that that we may have we were okay with the draft that we received over the summer, but would need some time to review this latest draft before we could weigh in as an association. And I appreciate you interrupting in the meeting so I could get that.
Thank you so much for that clarification.
Yeah, Mr. Chairman, let me clarify. They actually called me about that first issue, and then I asked about this, and that's why I asked in this forum, have they signed off on it? Because the concerns that Ms. Faison just mentioned at the end there were things that they brought up. And so I wanted to know whether this bill draft covers those things. So just to clarify.
Well, I think this bill draft has been changed in some ways since Ms. Faison, since Jennifer, what was the draft she reviewed was an earlier draft. So the question, I don't think anybody knows right now what they think.
So the answer to my question is no, they haven't signed off on it yet. That's my question.
Yeah, and Delegate Sickles, I appreciate that. I wasn't aware that that was a separate conversation from the issue we were talking about the other day, which is similar, but not exactly the same. So appreciate that.
Okay, Sarah, is there more? Okay.
But wait, there's more. We have a couple more things to work through real quick. Again, trying to draw your attention to some of the more important substantive changes in this draft. We do note that in a case where we were just talking about where there's monitoring and there's a conclusion that an emergency custody order is important to be obtained, that order is obtained. We have added language towards the bottom of page 11, noting that the entry of an emergency custody order, temporary detention order, or an involuntary inpatient treatment order will suspend but not rescind the MOT order that the person was initially under. So that is a substantive change as well. The draft also makes several changes to the court review process. There are a number of different situations in which a court would need to review a mandatory outpatient treatment order or plan. And this draft sort of combines all of those into one section. Currently, they are spread throughout the chapter, the title, the article, in different areas as we talk about different things that might need to be reviewed. So this draft does pull all of those into one section. That is section 37.2-817.2. Starts at the very bottom of page 11. That's where the title of the section is. And then we move into the substance on page 12. What you'll see here is that in the second paragraph, it's all new language. This draft combines into a single place. All of the individuals that may petition, or all of the entities that might file a petition for any of the things that can happen when you have a review of an order or a plan. So it lists out the person who's the subject of the order, the community services board, the treatment provider, et cetera. There, I'm not going to read it all to you.
The question is, are there new people are we making substantive changes to that process?
Well,
are we including new people or excluding old people from the process that already exists?
Yes. It's a little more nuanced than a yes or no answer there.
Okay.
So what happens right now, and in the next paragraph, so you understand what I'm talking about, lay out the things that can happen when a petition has been filed. So under the code, not all of those people can file a petition for all of those things. Now, the way it's drafted, all of those people will be able to file a petition for all of those things. So in theory, you are now expanding the pool of people who can file a petition for certain types of certain motions. So to be clear, what you can file a petition for is a petition to enforce a mandatory outpatient treatment order, a petition to modify the mandatory outpatient treatment order, or a petition to rescind the mandatory outpatient treatment order. Currently, again, not all of the people in that paragraph are allowed to file petitions for all of those things. So yes, it does expand who can file a petition in some cases. Do you have questions about that before I move on?
Move on.
Okay, moving on from there, you will see some changes. We're almost to the end. We're getting there quickly. Some changes for what happens if you have a petition filed, you're going to have a hearing. There are some changes to what happens if the person fails to appear at the hearing. That's in subsection C. So this will change the process a bit to allow the court to issue a subpoena for the person to appear at the hearing, plus an entry for an order for a mandatory examination. The code already provides for mandatory examination when we conclude that that is necessary and the person does not want to comply with that order. That's in subsection B. So subsection C makes that change when we get to the point of a hearing where you want the person to attend and participate. Additional changes are in subsection D. There's revising of the criteria there, doesn't change too much there. Moving through that section, you'll see some changes to what the judge or special justice can do at any of these hearings. Clarifying, for example, that the court can modify the order, can order the person to adhere to the order, those types of things. The last big substantive change that I want to draw your attention to is on page 16. We add a new subsection E to this section of the code. That section allows the judge or special justice to schedule periodic status hearings for the purpose of obtaining information about the person's progress while subject to the order and the plan. That's not something that the code currently considers. It is a new type of hearing that is being added. In this case, so currently under the code, the CSB can petition for a review if they feel that the person's not complying with the order or say the services are no longer available. So those options currently exist. This is a status hearing that the judge or special justice would initiate to simply get more information about what's going on and check in with the parties. Sorry. It does note that the status hearings can be held without counsel present by mutual consent and does include some information about what can happen at these hearings. This section provides that at the hearing, the plan can be amended if there's agreement of both, or there's mutual agreement, but that contested matters cannot be decided during the status hearing. So you wouldn't have enforcement, rescission, or renewal of the order at a status hearing. I think that's really the main substantive changes in this draft. It's a lot, and if there are questions about any of it, I know it's a lot to sort of walk somebody through at 4 o'clock in the afternoon after a long day. So
It's more than a mouthful, but it's something we've been talking about for a couple of years, I guess, and we've sent this to Professor Bonnie's group, and I know Delegate Hope has put a lot of work into it. Delegate Bell has done a lot of this work too. Does anybody have any questions or any comments? Allison Tysinger from the Attorney General's office here to answer technical questions.
Mr. Chair.
Delegate Bell?
I'm actually, let me see if other people have questions. I'd like to talk about this for just a minute when the questions have been answered.
Mr. Chair, this is Delegate Price. The only other thing, if Delegate Bell wants to go first, the only other thing that I was wondering is if there were people with lived experiences with MOTs that had input for if anybody was signed up, because I know when I was chairing the Behavioral Health Committee, that was one of the things that was missing. And I understand that it was part of the process that got to the report from the summer, but specific to the language that I think you're gonna ask us for our vote on to be a recommendation, I just wanted to see if there was input from Vocal or anyone on that.
Well, there are a number of people signed up, but I don't know if any of them are here to speak to MOT. In the past, people have come to commission meetings about MOT specifically. people that have been interested in significant changes, and I don't know if they will be completely satisfied with this legislation.
Yes, Mr. Chair, I definitely understand that there are going to be underlying philosophical differences in general on MOT, but just wondering if specific to the language that we are looking at, if I'm going to be asked for whether or not I recommend a piece of legislation, I would just want to know what we've heard from, and just to say that we've heard, you know, at the very least.
Well, Anna Mendez, you've popped up, but also Professor Bonnie has his hand up. Let's hear from Professor Bonnie, and then I want to go to Anna Mendez.
Well, just let me say quickly, in terms of input, we expanded the reach and membership of the work group a couple of times and actively recruited participation by people with lived experience, and this played an important role in what was done at the by the meetings. And even though I know there are some issues that are fighting issues, you know, that you just can't always get everyone to agree to, there's a lot of language in the proposal that specifically relates to engagement all the way through of people in the making of the plans, and that's one of the reasons that the people who with the authority to initiate review, it includes obviously the person who's under the order as well as other people, enhances the role that advanced directives can have, for example, if they are needed. But there's quite a bit of language that Sarah could identify that specifically enhances the role of the person in the development of these orders.
Let me ask you, Professor Bonnie, you said that you actively sought the input of people with lived experiences.
Yes.
Did you receive input from people with lived experiences? Were they involved in?
Yes, yes, they were on the, yes, including people who are on the work group. Absolutely, for sure.
Okay, there were people on the work group with lived experience.
Yes, absolutely.
Okay, Anna Mendez, and also Jenny, how do you pronounce Shatan?
It's hard. It's Skatine. It's like school,
Okay.
the SDH.
Okay,
Thank
well,
you, Senator Deeds.
After Anna Mendez speaks, I'm going to ask you to speak.
Thank you.
Thank you, Senator Deeds. My name is Anna Mendez. I was on the MOT work group. I'm also the executive director of Partner for Mental Health in Charlottesville, Virginia. We are an advocacy organization that is interested in protecting and promoting the civil liberties of people with mental illness. Delegate Price, I'm very grateful for the fact that you asked this question. Thank you very much. Until we have seen the precise language that is being presented, our position on MOT is actually so nuanced that I don't feel like I can sit here, somewhat like Jennifer Faison said for the association, until I'm seeing the exact language, we really cannot say whether we support this bill or not. The one thing that I think is incredibly important for me to address is the fact that to the extent that we do support a system of MOT, it is in order to ensure that Virginians are receiving treatment in the least restrictive environment possible. I want to just make it incredibly clear that we do not want to live in a commonwealth where every person who ever meets ECO or TDO criteria is automatically hospitalized. We would need 10 times the state hospitals that we have now. The point of MOT must be to keep people who would otherwise be hospitalized in their home environment and to prevent expensive hospital usage.
I agree with that, Ms. Mendez. Let me ask you, you were involved in the work group though. Were you satisfied with the draft that Professor Bonnie prepared this summer?
I am very much in agreement with that. The most recent draft that I have seen has some changes to what I agreed to this summer. That's why until I see what you're actually considering, I can't give a thumbs up or a thumbs down.
Okay. Now, Jenny, and I apologize again, your last name, how do you pronounce it?
Please, no apologies, Senator Deeds. It's Skatine. It's like school, the SDH, and it's very difficult. So I appreciate the attempts.
Okay. Thank you, Ms. Thank you, Ms. Skatine.
You got it. Thank you. So first of all, thank you for the opportunity to speak, Senator Deeds and committee members, and thank you for your really crucial work on this issue. I know it's really complex. We've been dealing with it for a while, and so thank you for all you've done. I'm with the Disability Law Center of Virginia. We are Virginia's protection and advocacy agency. We're federally mandated to provide oversight to people with disabilities in the Commonwealth. And we were also involved in the MOT work group as well. And so we value that opportunity to work with you guys. We do support more education and training on these really important issues. However, we do oppose the removal of choice of the individual to direct and control their own recovery. As we know that forced treatment does not lead to better treatment outcomes. And with that, thank you for your time, for allowing us to. Oh,
Ms.
yeah.
Skatine, let me ask you, you were involved in the work group. Did you support the draft that Professor Bonnie was floating around this summer?
We did not come out for or against that specific draft.
Okay.
However, at the work group, our representative, Michael Gray, one of our senior attorneys, came out against removing the person's actual consent to mandatory outpatient treatment.
Okay. Thank you very much.
Thank you again.
Edmund Creekmore has come into the room, and I assume you wanted to speak to this issue as well?
Yes, I am Dr. Edmund Creekmore. I'm a licensed clinical psychologist and a TDO evaluator for a major hospital in the Central Virginia area. I am also the legal guardian for an adult who has a history of serious mental illness. I had a prepared statement, but I'm going to dispense with that because I have not had the opportunity to actually review the language. I do not have a copy of it, but let me just say that I share Ms. Mendez's perspective that she expressed in her last appearance at the committee, that a key here is not so much the availability of specialized intensive outpatient services, it's family involvement. And in my work as an independent evaluator, just getting a hold of family members within a 72-hour time frame in a crisis situation can be arduous and challenging, to say the least. I'm very late in the game here in terms of the mandatory outpatient changes, but it seems to me that legal guardians should be permitted, at least in some of the petitions and some of the aspects of the modification of mandatory outpatient orders. In reading the June report, it seemed to me, I may be mistaken if there have been later developments, but it seems to me that most of the proponents from the CSB wanted the family participation only to consist of the TDO petition. And if that is the case, if I'm understanding that correctly, I think that would be a mistake, particularly since a legal guardian under, I believe it's 64.2, 2019, are required to advocate for their loved one who has a disability, who has a serious mental illness, and should be allowed to petition. I also am very much in support of involving families in this process. I realize there are some aspects of the MOT order that probably would not be appropriate to have the families petitioning for, but I think certainly there are others where I would like to see more active family involvement. Also, I'd just like to mention briefly, this is not addressed anywhere in the report, but if our challenge is to try to open up inpatient bed space, we should consider patients who not only are able to abide by an MOT order, but who don't agree to it or are not able because of lack of capacity to consent, we should be considering some kind of track, it seems to me, for patients who meet the criteria for involuntary commitment, but who are able to abide by an MOT order, who do consent, are capable of consenting, and who would benefit from outpatient. And I don't see that issue being addressed at all. I think if there was some kind of track, I would call it mandated treatment, not mandatory treatment, where they could be diverted for even the kind of 30-day inpatient order that we're talking about. One specific suggestion or recommendation I would like to make from my experience, I've been doing these TDO evaluations for 15 years, would be to expand the 72-hour period. Many of these patients can be stabilized if we had a longer period of time for the psychiatrist to get some of these patients that are there because they're non-compliant with antipsychotic medication within a 96-hour period. A number of them could be stabilized and diverted to outpatient care. And I think that could actually be done under an MOT order on a voluntary basis, where they are given one opportunity to elect to go under a court order voluntarily on an outpatient basis, where they could, if they are materially not compliant over the 6-month period or whatever may be envisioned, I know that's the time frame that's been proposed, then they could be, then you could get a court order to revisit that issue in terms of more of the mandatory type of an order. That would be something that I think would be very helpful, could divert a number of those patients. We're talking about patients who have brief psychotic episodes. We're talking about some patients that are arguably under the kind of quasi-parent, parents patriae type of cases, who could be nonetheless capable enough to consent to outpatient treatment, to be one of those categories of patients who could be diverted. And I think that that would allow more family involvement. That could be done primarily through the CSBs. I would like to see something more along those lines. For those patients, the way the code's written right now, where you have to have failed 2 times before you can be referred to outpatient care on an MOT order, I think that's a mistake, because I think there are patients who could be stabilized, referred to outpatient care under a mandatory order, but not if you have that code in there that they've got to have failed 2 times. I mean, the family member who I am a guardian for would very much benefit from a plan where, a code where this particular family member is doing very well, but God forbid if they should ever relapse, if he should ever relapse after having successfully petitioned to have the guardianship dismissed. And then at some point, as individuals with serious mental illness are prone to do, could possibly benefit from a different kind of MOT track, where that my ward could go into a program like this on a voluntary basis, be picked up by the CSB, or have his status reviewed, deal with whatever issues may need to be dealt with, but where court oversight would be a last resort, be an option.
Okay, thank you very much. This is a little more complicated than a whole lot of bills that make it, that go through work groups and subcommittees. But we've got this legislation. We've got to figure out whether we want to put the imprimatur of this joint subcommittee on it. And so I'd like to hear from the members.
Mr. Chair.
Delegate Bell.
So I want to repeat something I said just because I think the speakers just underlined it. This is not a bill where we can work real hard and reach a consensus of everybody who's interested in this issue. And to put a finger on it directly, we have heard over, gosh, at least I can think of 13, 14 years from mentally ill individuals and their advocates who say, of course, they are not seeking additional oversight over their lives. We have heard from family members for the same period of time begging us to give them some way to try to keep their loved ones getting treatment. There's no way to reconcile those. You can split the difference. You can come up with a place you draw the line. But if anybody on this group thinks they're going to have a group that everybody who's spoken at our meetings thinks is a great bill, you're mistaken. It's just not this space. We have a population, we have overpopulation at our hospitals. And it's been a problem long enough that it's not caused by COVID. It's not caused by a bad summer. It's just we have a shortage of bed space. We have people in there who we believe can be safely released, but only with very tight oversight. In other words, you're making sure they go to the meetings, making sure they go to the meds. That's the sort of the first group that would be MOT eligible. The second are the people that keep getting out, decompensating and coming back into the system and going to the emergency rooms. That's the second group, where if you have repeated violations. And so you sort of group one would get less oversight. They're inpatient, they would now be outpatient. Group two would get more oversight. They're not on any oversight, and this would give them mandatory outpatient treatment. That's sort of issue one. Issue two is because we silo our resources, and this is directly to Delegate Sickles' point, everybody agrees that it will save a lot of money, even with very, very tight oversight, to do it outpatient rather than in. But the CSBs are not directly receiving the benefit thereof. And so, Delegate Sickles, this is an issue you guys have on appropriations all the time. We see it in this space, but from the Fairfax CSB's perspective only, there are times it would be easier for someone needing a lot of oversight to be inpatient. That's not right for the person, it's not right for the overall system, it's certainly right for that particular lens. And so I think that for those reasons, if we can get this right, I think it can do a lot of good. Now, to get it right is the hard part. And Mr. Chairman, I think that you and I have been at this long enough to see examples of what happens when the CSB misses an appointment or doesn't show up on time, or the meds don't get taken and nobody does follow-up. And obviously the results are as serious as they can possibly be. And so certainly I would not support this unless we have that level of buy-in from the CSBs and an acknowledgement at the hearing date. The CSB comes in and says, we can't see him but every 2 weeks. And the doctor says, well, you got to see him every 3 days or else this isn't going to work. That's a bad setup. That's not an MOT that should be granted. And it's not in this draft. Sarah and I have been working on language all afternoon, but at some point there has to be language that says that we need that decision to be made at the time of the hearing, not 6 weeks later when they haven't seen the guy in 3 weeks and he's decompensating somewhere and they're afraid that he'll never, come back into the office. And so candidly, that's someplace the CSBs are going to have trouble, because now you're saying that this can't just be seen like everybody else. This is going to have a heightened level of scrutiny by the CSB, and the special magistrate is going to have a higher level of scrutiny over the CSB. And so I think they're hard issues. They're nothing that can't be addressed, but we kind of have to have a consensus in this group in support of it. And it seems like in the big picture, we need these. There's all these reasons why more people should be on MOTs that are not. And the current system is not, in fact, the numbers are really bad. We just don't have anybody who is doing this on the books, as Delegate Hope said, but there's not, in fact, anybody, very few MOTs are being granted. And so with all that, I hope we can reach a point where we can move forward. Now, I hope this reaches a point, or on the other hand, where if it doesn't work, that everybody just agrees we'll come back next year rather than say it has to pass, because certainly if it becomes a has to pass bill, then we're going to get bad output. But those are my thoughts, Mr. Chair. Thank you.
Thank you. Are there others?
Mr. Chair, this
Delegate
is,
Price.
yeah, thank you. So, okay. I completely understand everything that I just heard, especially underscoring that there are philosophical differences about whether MOT should exist or not. But looking at the bill that we have before us, I received it this weekend and am hearing the walkthrough now. Can we reiterate what are the places where I was hearing that there's language that was crafted that's not in it, that there are policy decisions that need to be made? Where are those points if we are about to say whether or not we support that? What is it that we are going to vote on if this bill is still being worked on? I do not think that this is something that you can vote on in concept and move forward. Like if every single thing that came before the committee, as soon as the patron said that it was supported by the deeds committee, it's like conversation stopped. They've already done the work. Let's pass it. So I hold that to be very, very weighty in what we're doing. So I just want to know what are the parts that we need to still work on?
I worry about that too. It's a question of credibility with this joint subcommittee. But actually what Delegate Bell talked about, the people that have come to the commission in the past to talk to the joint subcommittee in the past, talk about MOT have been in two groups. There have been people in the community of those who struggle with illness who say, we don't want anybody to tell us what to do. We don't want to have to do things we don't want to have to do things we don't want to do. And then there are parents who come to us who are desperate to take care of their family members. They're desperate to take care of their kids. And I can relate. I want to, but I also understand that mandatory outpatient treatment does not work in every part of Virginia because we just don't have the services in every part of Virginia to make mandatory outpatient treatment work. There's one CSB that still farms out 100% of their work because they don't 100% of their professional work because they don't have a significant number of people within their catchment area to do the work. So this isn't going to work everywhere.
Yes,
Sarah,
definitely understood, sir. I get that. But if I come at this, let's just say hypothetically, I come at this as someone that believes that MOT is good and what we're trying to get to as Delegate Bell, I still am unclear as to the parts where we need to make decisions, policy decisions, in order to get to a final draft of the bill.
That's very fair. It concerns me too that we don't have all the language worked out right now, and I appreciate all the work that's gone into it. Sarah, what are the things that have to be worked out?
Yes, Mr. Chair. So there are a couple things, and it's kind of hard for me to know exactly. As we draft the words that go in the code, we all know that words matter. Specific terms matter. How we write the words matter. So as we work through that process, it continues to highlight some places where we may not have all of the information. Some of the details may not have been sort of totally worked through. So that's an ongoing process with a couple areas of this bill. It's not that people have failed to do the work. It's just that when you reduce it to writing, it highlights some additional issues. The places that you would need to focus on this and the places where I think we still need to do more work in the next 24 hours are, first of all, the first big area that I think we have not completely worked out the details in is the relationship between, it's around the step down, the mandatory outpatient treatment step down process. That is subsection C1 that you will see starting on page 3 of the bill, or page 4 of the bill, page 4 of the bill. We need to make sure that we understand how that order works and what the intent of that order is. I've talked to a lot of people about this draft over the last 3 days, and I think we know what the goal is there, but we need to clarify some of those pieces. Is this a case where we have 2 orders, one for inpatient and then one for outpatient? Is it a single order that provides for a set period of inpatient and a set period of outpatient determined by the court? Is it a single order that says there will be some period of inpatient followed by some period of outpatient? and then who makes that decision if it isn't set by the court. That's an important process because we want to make sure that mandatory outpatient treatment is available, from what I understand. And we want to make sure that the language in the code is workable for the people in the field trying to implement it, which means we've got to make sure those connections are accurate. So that is one area where I think we need to do a little more work on this draft. Another area where there needs to be some work is there's just a little bit of cleanup work that needs to happen in some of the sections talking about where we went from having a separate discharge plan and mandatory outpatient treatment plan to a single mandatory outpatient treatment plan, to make sure that the requirements for that plan, regardless of how you get there, are very clear. One of those pieces is the thing that Delegate Bell has talked about. It's not in this draft because I had to get this out for you in time for you to look at so that we could have a meaningful conversation. But Delegate Bell's concern around CSB monitoring, I have actually drafted it up as a line amendment to this bill if you'd like me to read it to you. I can do that.
Yes, please.
What page would we be looking at, please?
Yes. So Delegate Bell's concern about ongoing CSB monitoring to make sure the person doesn't meet the requirements of EC or TDO. You're going to want to go to line 209 of the draft. That's on page 8. In this section, subsection G, at the beginning portion here, lays out the components of the mandatory outpatient treatment plan that will in this case apply in any case in which the person goes to straight outpatient or step down. We would add an 8th criterion there at the end. On line 209, 208, after the old language, the plan, you would insert comma and Romanet 8, set out the provisions that the Community Services Board will follow to ensure that the person does not meet the criteria for emergency custody pursuant to 37-2808 or temporary detention pursuant to 37-2809 at any time during the period of mandatory outpatient treatment. There will be a corresponding change on line 279 of the draft. This is in the section of the code dealing with monitoring mandatory outpatient treatment. Line 279 is on page 11. The Second Amendment on line 279 at the beginning of that subsection would read, the Community Services Board Community Services Board. Well, I've got a typo in my, let me make sure I'm giving you exactly the right thing. The Community Services Board shall report monthly regarding compliance with the provisions. Oh no, that's not it. Let me find that one for you. 1 second, I've got the wrong one. Delegate Bell, do you have that one in front of you, the language we worked out? I've got the old one.
I don't, I'm sorry.
Okay. No, 1 second, I've got it right here. Let me just pull it up.
Cree, if she needs a Senator Deeds, Mr. Chairman, I'm sorry.
Delegate Bell.
If I could speak to what we're trying to do here. I mean, the issue would be you have somebody who right now they're saying should be in the hospital. And we just want to make sure before that special magistrate says, yeah, they can be handled in the community, that there's a real clear understanding of what the CSB is going to provide. Not for all the little stuff, not they'll meet us at this place, but not that, or the appointment will be at 9, but not at 10. But for those things that actually would, if they don't happen, and we're mostly talking about staying on your meds, but for those things that don't happen, we'll put them back in ECO or TDO status, that we know how the Community Service Board is going to monitor those, and that they do it. And what I mean by that is the last thing we want would be the special magistrate saying, Mr. Bell is ready to be released, assuming we get a lot of oversight. And the CSB doesn't have the capacity to do it, as someone has said, or doesn't plan to, doesn't take it seriously, all the different ways it might not happen. Again, that's not a big deal for most things, but if it's those things necessary to make sure the person is safe, then that's the ones we want to make sure it's very crystal clear from the release plan, and that there's oversight over the CSB to make sure it gets done, because I think otherwise we're going to lose some people. And so that's what we're trying to create. You might have 50 things in the order, but only 2 or 3 go directly to safety. And those are the ones we want to make sure that everybody understands are those that are most important. That's what I was trying to get at.
I suggest that medication compliance itself is a good indication. If sometimes that can be tracked through a pharmacy, that a patient has not been filling their medication. This kind of thing increasingly can be tracked by psychiatric providers. That would be certainly one early warning sign that a patient is not in compliance, and usually precedes a relapse or psychotic episode.
Mr. Chairman,
Delegate Bell.
the one we purposefully realizing that different people have different needs to avoid being rehospitalized. We didn't want to put too much in the code. We did want, though, it to be explicitly part of the plan and not just listed in the plan, but including how the CSB was going to do it. And what I mean is, my understanding of how quickly people can decompensate is that there's some that it's not that big a deal, and some, if you miss your weekly check-in, the person you're used to seeing is on vacation and nobody bothers to cover that, it's a catastrophe. And I think that we would want to have that identified in the plan so that the CSB can say, we don't have the capacity. If clinician, I'm looking at names here, if clinician Ranson isn't there, we don't have a backup. Well, that one can't do a weekly check-in because every so often Ranson's not going to be there. I just want to make sure that this discussion takes place at the plan creation moment, not after something terrible happens. And that's what I'm trying to get at here. And then we said that for these, at least, we need the CSBs to be reporting in. We picked 30 days out of the air. I don't have 65, just 30 days seemed like something that you could say. And we have, if they said if we got to see Bell once a week, then every 30 days you'll say we saw him on these dates. That's all.
Okay, I think Sarah has something.
Yes, Mr. Chair, and that's the second amendment. I had one of our earlier iterations of it in front of me. The second amendment to address what Delegate Bell was talking about would be on line 279 after C. Say the Community Services Board responsible for monitoring the person's compliance and adherence to the community or to the comprehensive mandatory outpatient treatment plan shall report monthly in writing to the court regarding the person's and the CSB's compliance with provisions of the mandatory outpatient treatment plan, describing how the CSB will provide monitoring and oversight necessary to determine the person does not meet the criteria for ECO or TDO. So it picks up that piece that Delegate Bell is asking about for the monthly report, setting out exactly how the CSB is complying with that new monitoring requirement.
Okay. Yes, ma'am. Ms. Mendez.
Thank you, Senator Deeds. I do feel quite handicapped not having a physical copy of what you are referencing in front of me, but I do want to say that having said that, what I feel like I'm hearing Sarah say is that we're introducing language that would end an MOT at such a time when a person met ECO or TDO criteria. And I just want to reiterate that our support for having a more robust system of MOT is to create a system in which people who do meet ECO or TDO criteria are able to stay in the community rather than being hospitalized. 90% of the time, the way that we're using MOT now is direct MOT, which means just that without MOT, the person would in fact be involuntarily committed today. So if we introduce language into the code that says once a person meets ECO or TDO criteria, they can no longer be under an MOT, then we've just obliterated effectively direct MOT. And again, I apologize if I'm misunderstanding. It would help me considerably to have the exact language directly in front of me. But I really want to say we strive very hard to find the third way, the way that is not the family way or the patient way. And I want to make sure that that's not lost in this conversation. Thank you.
I appreciate that. But you had the advantage of sitting with the work group. None of us have that language in front of us except Sarah and Delegate Bell. Professor Bonnie has his hand up. You're still muted.
Bonnie.
Yes. As I understand, it's very frustrating for everyone not having the document right in front of them, but all of these issues were discussed fully in the work group. I think many of them, without my looking at the words right now, are actually dealt with specifically in, the draft that you have. For example, the point that Ana Mendez just made, actually, the draft says that the mandatory outpatient treatment order would stay in effect, even though there might be the ECO or the TDO issued. Obviously, that's going to be addressed at a later time. Also, Delegate Bell, as you can tell, we listened very, very carefully to what Delegate Bell said as a result of the last meeting and some of the language that Sarah just read. There are other points in the draft too that specifically are responsive to this issue of identifying those key factors that we want to have an ongoing monitoring and a record of, on an ongoing basis. So I actually think many, many of the issues that have been discussed here actually are dealt with, in the draft. And obviously people will have an opportunity to look at it if the commission actually, moves forward with it and it's introduced. There's plenty of more time to kind of iron out anything. But all of these matters are reflected, I think, in the proposal. And I think just one other important point here. One of the key things as a theme here is to increase the role of the judge in this. I mean, all the efforts that we're trying to get from all sides to listen, to the participants here and increasing the role of all the participants, the family members, as well as the individual, him or herself, the guardian, and so on. Every effort has been made to expand the participation and to give the judge the responsibility for monitoring how things are going. That's one of the important things about the status hearings, because everybody can participate in that. It's supposed to be supportive in a quasi, clinical way. And so I think that's another important part about this in order to implement what Delegate Bell wanted to do here. Rather than identifying several specific things in the code, it was to say make the decision would be made at the time that the order is drafted about what the key aspects of it are that need to be monitored. And then they will have to be recorded and monitored on an ongoing basis. And the judge can, serve that function. So I think, as I've been hearing all the things that have been said here, I think when you get down to the many, many amendments that have been made to the existing code, they are responsive to all of the concerns that have been raised, really on both sides, increasing participation by everyone, but also, assuring that we can be confident that the services hopefully are being effective.
Mr. Chair.
Delegate Price.
So with that, I'm trying to keep track of conversation and relating line numbers. So does that mean that we would be not making any changes to section E, lines 410 through 416? Does that say what we're saying it says, or that's another place where we need to make some amendments? And I guess that's a question for council.
Mr. Chair, that is another place I'd point out you may want to consider some additional clarifying work. This section, for those of you who have the draft in front of you, is the status hearing section. So this is an area where I think we may need to look at addressing procedure a bit more. I know that the intent is to have this be an informal and flexible hearing that a judge or special justice can call to collect information. But this would be a hearing. And I think it is important to note that as such, we do need to think about clarifying things like who is entitled to be at the hearing. What is the notice requirement? The code specifically states that status hearings may be held, or this draft specifically states that status hearings may be held without counsel present by mutual consent. I think if you are going to say that, you do need to make clear that the person is entitled to counsel. And it does raise the question of what happens if the person doesn't have counsel or is indigent and cannot afford counsel. So again, not insurmountable issues, but some things that I think we may want to look at clarifying when we're talking about adding a hearing to the code, simply to make sure that we are addressing procedural sort of rights and concerns there. That will also have some impact on workloads for the CSBs, the special justices, the court, and some of the other.
Currently, there's a process for appointing a lawyer for people. I guess we could just relate this back to that section, couldn't we? In the special justice process, there's a procedure set up for an appointed lawyer. It gives, but I don't like to draft legislation on the fly, but I guess it's better here than in full committee somewhere. I'd rather get it right now. What else?
I think at this point, that's most of the major issues.
Okay. Well, what members, what are your views? Are there motions?
Mr. Chairman,
Delegate Hope.
Since I'm the instigator of all of this, I didn't know how this commission meeting was going to go today, and I certainly didn't expect it to go this way, quite frankly. We've started this process. This has been 2 years of this work group in discussing this, and they produced, and I won't go into the history of it, but they did produce this summer a consensus document that had a pretty broad level of support. What we're trying to do right here is just get the words right. I don't think what you're hearing are substantive changes to what the work group agreed to. I know that members of this commission weren't on the work group, but I'm not sure how we could have done this process any differently. We do need to get the words right. I think that's where the issues are. But I think that largely the substantive changes that we're talking about right here are part of the consensus of that work group, that they produced a report and produced this document that I hope you've reviewed over the last month or so. And so now we're just, and I think, we had to pull an audible here because the initial draft that we had was the substantive changes and the reorganization. And I think it's just a lot of stuff. And that was the draft that you all saw at the last meeting. The changes that we've made, though, has been to pull out the substantive changes and just do a bill that's only those changes. And I think it's now just a process of trying to get those words right. I don't sense that there's a comfort level in the commission that the words are right now, as I look at the January the 11th, 2021. And so I'm not sure that that there's a comfort level to vote out what is currently before us. But I just want to remind everyone that this clearly is an important issue, and it'll be a shame to waste another year if we just can't get the words right.
Well, here's what I'd suggest. Delegate Hope, I'm not certain. I mean, we haven't heard from every member, but there's been some concern about the language of this, and we do have to get it right. I would suggest that you go ahead and introduce the bill. I want to sign on as a co-patron, and there may be some other people that will, and maybe whatever language issues exist, we can get them worked out before somewhere in the process. Is that okay?
No, I hope that's the case. I do intend to go forward with the bill like I have for the last 3 years.
Yes.
And I will do that. But hopefully there's an opportunity for us to get the right people in the room who are interested to sort of go, try to get out what we can, recognizing that we're going to have to come back again next year to get the reorg. It's too important just to let it go away.
And I just expressed one view. There may be other members who want to adopt this, and I'd like to hear from you.
Chair.
Senator Barker.
Yeah, Mr. Chair, I agree with your approach on this. I think that Delegate Hope should go forward and introduce the bill. And I think that we need to have some people who will work with him on trying to come up with the language that is what people are searching for right now. And I don't see that there are a lot of major issues of people being substantively concerned about this that would not agree to anything here. I think there is flexibility in terms of being able to get a resolution of this throughout the process. And I think so. I think we need to make the effort to get it done.
I think so.
And having been someone who had, a bill along this line about 10 years ago, sort of trying to get things started on this whole MOT stuff, I'd be happy to help out on anything that would work. So.
Okay. Okay. Well,
Mr.
then that,
Chairman?
Senator Hanger.
Yes, I would just add to that I'm supportive of the concept. Spent a good bit of time working on specific wording there. I think if you get a couple people involved, Delegate Bell, Senator Barker, Delegate Price seems to be well invested in this, wants to get it right. So maybe a small group of them can hash this out for us before it gets in front of a hostile committee.
That sounds like a good idea. And Delegate Hope, I hope you bring the people on this commission to the table and make sure that you visit with people before the bill gets too far along in the process. So if there are issues with respect to the language that can be worked out, we get them worked out. So, I hope you don't have to introduce this bill again next year. I want to get it done. I want to get it right this year, if we can. Okay. I think there was one more bill we were going to consider, and that was a study resolution. Is that correct? Okay, Sarah.
Switching gears, last one. This is the piece we talked about. This is another ILPPP piece they brought to us for the last meeting around developing a secure, de-identified, renewable, and relational database of criminal justice, behavioral health, and human services records to facilitate development of effective interventions. We talked about it at length at our last meeting. The conclusion was to look at a House Joint Resolution or Senate Joint Resolution, a joint resolution, to move forward with this that would direct DBHDS to put together to study the feasibility of doing this and put together a plan. So that's the draft you have before you. I know Dr. Bonney has one change to this he'd like us to make. We need to add in some more of the criminal justice agencies. Is that accurate, Dr. Bonney? That was it, yeah. To make sure that we cover
this is basically a method to gather information on people that go into the criminal justice system that have mental health issues, mental illnesses. Is that correct?
Yes, sir.
It's a method to gain information we don't have right now.
Yes, sir. And it would include DBHDS, the Office of the Attorney General, the Executive Secretary of the Supreme Court, and several other organizations, state agencies, to come together to put this plan in place to understand where the sources of information would be, how that would be brought together, the safeguards in place, and how it would be used.
Well, I see Christy Wright from the Office of the Executive Secretary and Heidi Dix from the department are both on the line. Do either of you have any views on this study?
Mr. Chairman, this is Christy Wright with OES. We are happy to engage in the study, and especially if it's a feasibility sort of thing, to be able to talk with all of the possible sources of the information, and I think to learn more about what ILPPP is interested in seeing. There are certain limitations and so forth, but again, we're happy to talk about, the feasibility of it.
Okay, thank you. Heidi, do you have anything?
No, just to echo Christy's comments, we're happy to participate in this study because there's a lot of things that have to be worked out and with a lot of care. So I think this is a good approach.
Okay. And are there any of the members that have issues, or Delegate Price?
Yes, Mr. Chair, thank you so much. And I'm so glad that we were able to get to some sort of consensus. One of my concerns that I raised when we were trying to move, I guess, in this this direction where we were directing the department to be the convener of it. And this is not against UVA or anybody, but just I have not been another resolution for another topic not related to this. When I tried to put an institution of higher learning into the resolution to tell the department who they had to put in there that was outside of governmental agencies, it was said that those would be included in the other such. So I just want to say, for precedent's sake, are we changing how we normally do this by specifically adding in an institution of higher learning? And if that's what we're doing, I'm cool, because then that helps me when I go to my other conversation. But that was something that I was up against when I was trying to use one of the HBCUs for something they just said, and educational partners was, you know, I'm just making sure that we're not starting something that we aren't prepared to continue in other areas.
Well, I don't know. Have we noted ILPP in other resolutions? It's been done before?
I can't remember how.
Maybe not from this group,
Yes.
but Professor Bonnie, I don't think your mic's on, but you're nodding your head.
Sorry. Yes, I think in other contexts, you know, specifically in the mental health area, we have been mentioned specifically in the joint resolution. If it's a problem, you know, just say other parties, that would be fine too.
Okay, if it is a problem, we can just, we can figure another way to skin the cat. Well, what's your pleasure on this resolution?
Mr. Chair, I would move that we support this resolution from the Deeds Commission.
Okay, is there a second?
Second.
Okay, any further discussion? All in favor? Say aye.
Aye.
Any opposed? Okay, do we have a patron for that resolution?
I am definitely open to it if no one else got it drafted.
Okay, well, I think we'll have it drafted. I didn't know that anybody
Introduced, that's
I
what I
don't know that we had any, whether we had. Okay, this meeting has gone on a little bit longer than anybody thought, but we still have some people signed up for public comment. I'm not going to call on the people that have already spoken, but I want you to limit your comments to 3 minutes. The first name on the list for public comment that is not among those who already spoke, somebody named Nathan Mitchell. Is Nathan Mitchell still with us?
I just promoted them to panelists, sir, so they should be in the room.
Okay. Nathan Mitchell.
Mr. Chairman, thank you so much for acknowledging me. I will pass. Thank you very much.
Okay. The next one is Carly Nelson.
Actually, Mr. Chair, Jennifer Spangler is in the room, and I believe that she is the only other.
Okay, Jennifer Spangler then. Okay.
Hello, everybody. Can you hear me this evening?
Yes, we can. Yes, ma'am.
Good evening, Chairman and subcommittee members. Thank you so much for hearing my comment. I'm Jennifer Spangler. I advocate on behalf of myself, and I participated in the MOT and TDO expanded evaluator work groups over the summer. Just wanted to let members know, if you would like to speak with someone who has directly received services such as mandated outpatient therapy or MOT, emergency custody orders, ECOs, temporary detention orders, TDO, involuntary and voluntary commitments, and forced physical and pharmaceutical restraints, I'm happy to share with you. I can send out an email with my contact information.
Okay, maybe you'd want to share that with Sarah.
Okay, I can do that.
This is a public meeting. I don't want you to give us phone numbers or emails or anything in this public setting, but you can, if you get that information to Sarah, she can have it available for anybody that wants to talk with you.
Okay, that would be fine, or I can email your offices directly.
Okay. Okay, do you have, is there anything else you wanted to say?
I would just say that based on discussion, both tonight and in the work groups, I'm not sure the peer experience about how these services are delivered is quite understood.
Okay, I appreciate that.
No problem.
And honestly, we can all use a little education, I think, from that angle. Okay, there are people that I've got signed up: Carly Nelson, Linwood Harvey, Brent Fisher, Jennifer Metz, Chris Hathaway, Jonathan Green. Okay.
Mr. Chair, yes, sir. They are no longer in the room.
They're no longer here.
Yes, sir.
Okay. Well, I hope we didn't make them mad. Is there anything else that anybody has?
Thank you, Mr. Chairman.
Okay, well, thank you. And I would say Happy New Year, and I look forward to seeing you, but I think we've already seen each other for a good while this evening. So I hope everything goes well with this session, and best wishes to all of you. Thanks. Thanks for your work.
Thank you, Mr. Chairman.
Thank you. We're adjourned.